Welcome to this clinical case analysis. Today, our central question dives deep into fetal physiology, putting you right in the shoes of the attending physician. We're going to solve a high-stakes mystery and decode the true secrets of fetal vitality in real time. So, let's get into it.
Let's start by exploring the case of our patient, DFT. She's 39 years old and currently at 37 weeks and 5 days of gestation. Now, this is a high-risk pregnancy because she has gestational diabetes and is on morning insulin. With her maternal age and metabolic status, strictly monitoring the baby's well-being isn't just a precaution anymore, it's an absolute clinical necessity.
Looking at our diagnostic approach, we evaluate 5 essential parameters. Fetal tone is normal, body and breathing movements are present, and the cardiotachygraphy is reassuring. But here's the kicker. The ultrasound of the maximum vertical pocket of amniotic fluid measures exactly 1.9 centimeters. By the way, this whole non-invasive evaluation relies on innovations that are literally worthy of a Nobel Prize. It echoes the capillary perfusion principles of laureate August Krogh and the imaging revolution led by Paul Lauterbur, Peter Mansfield, and Alan Cormack, which allows us to peek into intrauterine physiology today.
So, based strictly on these 5 diagnostic clues, what is the correct fetal biophysical profile score for this baby? Is it A, 2, B, 4, C, 6, D, 8, or E, 10? Lock your answer in because we're about to systematically break this whole case down.
To figure this out, we have to decode the biophysical profile and crack Manning's scoring system.
The ultimate rule here, because in this case the clinical presentation is sovereign, is the famous rule of 2. The fetal biophysical profile evaluates its 5 variables in a strictly binary way. Each parameter gets exactly 2 points if it's completely normal, and 0 points if it's abnormal. There is absolutely no middle ground, and you do not get partial credit of 1 point. It's an all-or-nothing system.
Let's apply this rule to our patient's first 4 parameters. Normal tone, that's 2 points. Adequate body movements guarantee another 2. Breathing movements are present, so that's 2 more. And a reassuring cardiotachygraphy adds a final 2. Just like that, we've rapidly accumulated 8 points, which honestly builds a very strong yet potentially dangerous initial sense of clinical security.
But we aren't done. Now we face the fluid trap, where a single millimeter can change everything.
The ultrasound report gives us a crucial measurement of 1.9 centimeters. Taking an anatomo-topographic approach here, the amniotic fluid surrounds the fetus, providing necessary space and protection. In the 3rd trimester, this fluid directly reflects the functioning of the fetal renal and urinary system, relying almost entirely on the baby's diuresis for its constant renewal.
The strict clinical cutoff for a normal maximum vertical pocket is 2.0 centimeters or greater. Our patient's measurement of 1.9 centimeters falls exactly 1 millimeter short of that cutoff. And remember our binary rule. Falling short means that variable gets a 0. The patient has oligohydramnios, so this specific parameter scores nothing.
If we sum our 2 points for tone, movement, breathing, and CTG, plus a big fat 0 for the amniotic fluid, we land on our correct alternative, letter D, 8. The justification for this is anchored in classic fetal medicine guidelines. Any assessment where the maximum vertical pocket is less than 2 centimeters automatically zeroes out the fluid score, giving us a final precise sum of 8 points.
So we have our score, but what does an 8 out of 10 actually mean for the pathophysiology and our clinical conduct?
Speaking pathophysiologically, these parameters are divided. 4 of them are dynamic, acute markers controlled by the central nervous system indicating there's no immediate hypoxia. But amniotic fluid is a chronic marker of placental perfusion. If blood flow drops, the fetus reduces renal perfusion to prioritize the brain and heart, which causes the oligohydramnios. To borrow some secrets from the animal kingdom, this physiological centralization perfectly mirrors the diving reflex seen in marine mammals. Animals like the Weddell seal, the northern elephant seal, and the sperm whale contract their peripheral vessels during deep dives to ensure all remaining oxygen exclusively bathe their vital organs. It's the exact same survival mechanism, just inside the womb.
Applying an expanded clinical judgment completely changes the scenario. An 8 with normal fluid suggests a very low risk of asphyxia, allowing for expectant management. However, an 8 with oligohydramnios, that is a massive red flag for chronic compromise. So the therapeutic approach for our diabetic patient at nearly 38 weeks becomes urgent. Because of the high risk of prolonged asphyxia, we absolutely have to consider delivering the baby.
Now that we've solved the case, let's quickly eliminate the distractors and see why the other options fail.
In our analysis of the other alternatives, A, B, and C are just mathematically incorrect because they underestimate the fully functioning acute markers of the central nervous system. D is our correct sum. And E, 10 points, is a fatal clinical flaw. It completely ignores the oligohydramnios, forces a non-existent normality onto a 1.9 centimeter pocket, and completely misses the diagnosis of chronic placental insufficiency.
Let's wrap this up with a quick summary and some key exam tips to remember.
Here are your key points to lock in. The profile evaluates 5 parameters with exclusive scores of 0 or 2. Normal fluid volume demands a maximum vertical pocket of at least 2 centimeters. An 8 out of 10 combined with oligohydramnios points straight to chronic fetal distress. In summary, this systemic approach is the absolute cornerstone for high-risk patients, defining that fine line between observing nature take its course and intervening to save a life.
I cannot let you go without this crucial exam tip. The most dangerous trap in fetal evaluation is fluid volume. Never, under any circumstances, confuse the maximum vertical pocket with the amniotic fluid index. They have entirely distinct clinical rules and limits. The biophysical profile relies exclusively on the maximum vertical pocket, with its strict 2 centimeter limit.
A score of 8 out of 10 usually sends the message that everything's under control. But as we uncovered today, knowing exactly which parameters zeroed out changes the entire destiny of the patient. A difference of a mere 0.1 centimeters shifted our whole approach from wait and watch to consider an urgent delivery. So I'll leave you with this. Are you paying close enough attention to the tiny millimeters on your next ultrasound?